Okay, welcome everyone. My name is Jennifer Dill. I'm a faculty member in the School of Urban Studies and Planning and also director of OTREC, the Oregon Transportation Research and Education Consortium. We help put on this weekly transportation seminar, so welcome everyone. I think there may be a few new faces. So for those of you who do not know, before I introduce our speaker, we do webcast the seminar. So there are people watching live on the web, and we also archive the seminar, so some people will be watching it sometime in the future. Maybe you want to watch it again. And because we do webcast it, once we get to the end of our speaker's presentation and we open it up for questions, you need to use the microphones when you ask the questions. Most of you, there will be a microphone attached to the desk. Hold the touch button. Keep the red light lit while you're asking the question. If for some reason your microphone doesn't work or you don't have one, we'll come around with this portable mic. So please remember to do that before you ask a question. So without further, and those of you who are in the class, I'm going to send around the sign-in sheet. I'm going to start it over here, make sure it gets over there and gets back to me at some point during our hour. Okay. So without further ado, I am very pleased to introduce our speaker today, Brendon Haggerty. He is a program coordinator for Clark County Public Health, but perhaps more importantly, he is a graduate of the MURP program here at PSU a couple years ago. And so we're really happy that he's been able to take the work and the things that he learned in the MURP program and is now working on this very exciting health impact assessment work in Clark County. So I'm going to turn it over to you, Brendon.
All right, thanks, Jennifer. It's a pleasure to be here. And as Jennifer said, I'm a 2009 graduate of the MURP program and now working in public health. When I was at PSU, I specialized in transportation and paid a lot of attention to bike and pedestrian issues. And so now I'm in public health. A lot of people ask me, Brendon, you're clearly a transportation guy. You like bikes, you like trains. How did you end up working for public health? And sometimes I wonder the same thing. But I was offered the opportunity to work on a health impact assessment for the Clark County Bicycle and Pedestrian Master Plan, which was right up my alley. And it was it's really been an exciting piece of work to be working on. And the nexus of public health and planning has been just a very engaging area to be working in. So today I'm going to tell you just a little bit about what health impact assessment is, because that may not be a familiar idea to some people. Talk about how we've applied that in Clark County to bicycle and pedestrian planning, and then talk about some of the lessons learned. And I want to emphasize that a lot of this is a work in progress, so at the end when we move into a discussion, I would really appreciate to hear the ideas and the questions that you have. So health impact assessment is an emerging set of tools that is used to evaluate programs, policies, plans for health impacts. And it's similar to the idea of an environmental impact assessment that many of you might be familiar with. And some people think that it is actually included in the NEPA legislation. But there are some really distinct advantages to having it outside of that legal process. First of all, it's not as litigious, but it's also not as structured, and so it gives the opportunity to really try to draw in current research and to use both qualitative and quantitative methods to project health impacts of proposals. There are typically 5 steps involved in health impact assessment. Screening is when we talk about whether or not to do a health impact assessment. Scoping is when we talk about what are the health impacts that are likely, what are the ones that we need to research, what are the boundaries of the analysis, similar to scoping any project. Assessment really has 2 pieces. One is a baseline conditions assessment, and one is a projected impact assessment. Reporting, part of that is what I'm doing right now, is sharing the findings that you get from your analysis. And then evaluation is a particularly important piece, especially because HIA is kind of a new practice. And it's a big part of this particular health impact assessment because we'll be taking some time after the whole decision-making process is over, to evaluate how this information was used and how effective it was in the decision-making process. And I put up a couple of examples of health impact assessments that have been done. The Atlanta Beltline redevelopment plan was a very extensive one that was done a few years ago. Here in Oregon, we've had the VMT policy health impact assessment that Mel Rader presented at this seminar, I think maybe last spring. Another one in the region is actually from a legislative mandate in Washington State to do a health impact assessment on the 520 bridge replacement. These are just a couple examples, but there are ongoing health impact assessments around the country, and health impact assessment is a much more common practice in Europe and Australia. So why would it be important to be including a health impact assessment in a policy decision process? And when we think about health, in a lot of people's minds, that conjures an image of a doctor's visit or a hospital. But as this chart shows, health care from the medical sector really accounts for a relatively small portion of our overall health. The area outlined in red, behavioral patterns, environmental exposure, and social circumstances, account for a lot more of that. And that's really where planning and public health converge. Because if I said those things out of the context of this chart, if I said behavioral patterns, environmental exposures, and social circumstances, probably a lot of people in this room would think of, okay, that's urban policy, that's urban economics, that's transportation policy. So you can see that there's a lot of overlap, and health impact assessment is a great way to make that connection and to incorporate the health concerns into decision-making processes. Now, I'm going to borrow this from the New York City Active Design Guidelines because I think they do such a great job of telling this story. This is a graph of deaths due to infectious and chronic diseases in New York City in 1880, 1940, and 2005. The light blue bars are infectious diseases, and the dark blue bars are chronic diseases. And I put this up because I want to emphasize that chronic disease is the really dominant challenge of public health in the 21st century. As you can see, from 1880 to 1940, the percentage of deaths due to disease flipped, where all of a sudden chronic disease became the big concern. And if you think about what happened during that time, from the mid-19th century to 1940, New York City got a drinking water system, sewers, Central Park. In, I think it was 1901, we had the Tenement Housing Act. In 1904, the subway opened. And in 1916, we got our first zoning. And all of that happened prior to the discovery of most antibiotics. And so by 1940, infectious disease had more or less been conquered. But what that leaves us with is chronic disease. Chronic diseases are diseases that continually affect people, like diabetes, heart disease, and cancer. And the huge risk factors for chronic diseases are physical inactivity and poor diets or poor nutrition. And so that is really the goal of this health impact assessment, is to battle chronic disease, particularly with regard to obesity. And just so everyone remembers, and I'm just going to refresh everyone's memory, because I know you all know this already. The recommended physical activity is 30 minutes a day, 5 days a week, or 150 minutes a week. And the idea behind this HIA is to see how many people in Clark County we can get meeting that recommendation. But you might be thinking, okay, this is a bicycle and pedestrian plan. It's kind of a no-brainer. Why do we need an HIA? And indeed, the Transportation Research Board and Institute of Medicine made this kind of wordy statement in 2005 that basically says anything you do to make walking easier is going to cause people to walk more. And there are a lot of people in this room who are dedicating their careers to proving that. But what we can do through this HIA is to prioritize the programs, the projects, and the policies to maximize those health benefits. And one of the things that we know about health outcomes is that people of lower socioeconomic status, racial and ethnic minorities. A lot of vulnerable groups have worse health outcomes, even holding all else constant. So we can target some of the things that can improve health to maximize the health benefits in the community. I want to talk a little bit about the plan, what's proposed in it, what the background is. It's an ongoing effort, I think for about 18 months now. The final draft proposal was released, I think, the beginning of October. So we now have kind of a stable thing to work with. It includes three kinds of proposals as we've classified them at the health department. Projects, programs, and policies. And the projects are, as you might imagine, actual infrastructure. They are trails and bikeways and sidewalks. And a planning committee put together a list of these, a long list, and then, of course, prioritized them. And we ended up with a set that we expect will take us through about the next 6 years of bicycle and pedestrian facility development. There are 5 programs that the committee recommended, as you can see them listed there, and 6 policy areas, and each one of those has, a list of objectives and actions that comes with it. How we've approached this HIA is kind of in 2 stages. First, we did a rapid health impact assessment that was before a lot of the policies and projects and the proposals in general had been really developed. And that was really aimed at having input into the plan early on. And so a lot of that had to do with some quick baseline assessment and predicting the direction of the impacts of proposals, whether they would impact health and whether that was a positive or negative impact. And then we made some recommendations based on literature and based on the assessment. And many of those actually ended up getting incorporated into the final plan, as I'll explain. Currently, we're in the midst of a comprehensive health impact assessment that's looking at what was actually proposed when the final plan was released on October 1st. And that will have a more comprehensive literature review, a much more extensive baseline assessment. We'll look at the impacts both in terms of the direction, whether it's a positive impact, but also we try to get toward the magnitude. And as I'll get to a little bit later, that's pretty challenging. And then we'll issue some more recommendations. And then down there across the bottom, you can see a timeline of the plan. I started this work in January. In May, we issued the rapid health impact assessment. We've been working with the planning department since then, providing more input on the plan and doing a lot of baseline assessment. And then the comprehensive HIA will hopefully be issued in mid-November. The Board of County Commissioners, which is the decision-making body that will consider this, will hold their hearing toward the end of November. So hopefully after Thanksgiving, I'll be doing evaluation work and seeing what the effects were. For the baseline assessment, we started by looking at determinants of health. Social determinants of health are things like socioeconomic status, as defined by income and educational attainment, race, gender, age. We also looked at a range of built environment determinants and measured a lot of different indicators based on what we found in the literature. And in case that's a picture of the literature, in case you couldn't tell. But before I get into what we found with that assessment, I want to talk about what we know about health outcomes. What actually happens in Clark County? How do people's health reflect their environments? And so the map on the left here is of life expectancy at birth, which is a very basic health indicator. And I know you can't read those numbers because I barely can. But darker green areas represent higher life expectancies, and lighter green areas are lower life expectancies. And what this really shows us is that there's a basis for doing this work. There's a need because there's this disparity. From the lowest life expectancy zip code to the highest life expectancy zip code, it's about a 6-year difference in Clark County, which is lower than you might find in other counties, but the fact that there's that disparity there means that we have some work to do. I also included this map of overweight and obesity. by zip code, partly to show that there is a disparity, but also to show one of the key challenges that we have in health impact assessment work, which is lack of data, especially at smaller geographic scales. Zip codes, as many of you probably know, aren't wonderful to work with, but it's often the best we have for health data. And then in rural areas, like in northern Clark County, we tend to not have enough data to be able to report. So looking at the social determinants, I'll just give a few examples of each of the indicators that we looked at. So this is median income in 2009. We were able to map this at the census block group with updated data that was donated by Esri, so we're very grateful for that. And as you can see, the darker red areas are higher incomes and lighter areas are low incomes. The lower incomes are mostly clustered in and around Vancouver, which is right in here. And you can see that the map of race and ethnicity largely tracks with the income map, with most of the minority population in and around Vancouver. And this is non-white population. You can see the darker purple areas are higher percentages of non-Hispanic white. Moving on to some of the things we measured in the built environment, which is really what we were concentrating on. First, we'll look at bikeability. And this is not a very comprehensive index. All it is a measure of network density. So this is bikeway miles per square mile within census block groups. And as you can see, Vancouver is relatively well served compared to the rest of the county, but a lot of the area north of Vancouver is also pretty well served relative to the rest of the county. And keep that in mind because we'll come back to the bikeway miles. Walkability, we calculated an index for each census block group. And as you can see, consistent with the other maps that we've seen, there's sort of a cluster here in Vancouver, and then the walkability kind of gradually deteriorates as moving away from downtown Vancouver. I want to emphasize that for both of these maps, they're relative measures to the rest of the county. So the dark area here doesn't mean that it's a walker's paradise. It just means that it's better for walking than the rest of the county. And we'll talk a little bit about how we measured walkability because it was a bit of a process. We used a walkability index that has been developed by some of the active living research folks, and it's a combination of 4 measures. Land use mix, which is an entropy index. Connectivity, where we use connected node ratio. And I'm so excited about this presentation today because I don't have to define retail floor area ratio, I think, right? Normally presenting this, I find myself stumbling over that definition. But it basically tells you how tall the buildings are, and it's a bit of a proxy for urban design. And then finally, residential density. And you'll notice conspicuously missing from this index of walkability is infrastructure. We don't have really very good data on where sidewalks are or the quality of those sidewalks. And without doing a lot of intensive data collection, this is one of the best measures of walkability that we can do. But it's also one that is consistently related to physical activity, which made it especially attractive to us. So we'll look at that map again. And this time, you can see the grayed out areas are incorporated areas. Those are within city limits. The red line that you see is the urban growth area. And this is important because the bicycle and pedestrian plan is only targeted at unincorporated areas. So the areas that are not grayed out are included in the plan. In Clark County, you can see that a lot the Vancouver urban growth boundary is really quite big compared to the size of the city. And it's fairly dense for not being an incorporated area. We looked at many built environment indicators. One of them is park access, and so that you can see this is network buffers around park access points. And I think we estimated that it was about 44% of county residents had walking access to a park within a half mile. We also looked at schools, and this is an interesting measure that I think we're still refining. But what you can see in this map is the mean distance to school for elementary schools from every residential parcel within the attendance area for that elementary school. And so the dark blue ones have shorter mean distances to school. And it's kind of a first cut at telling you how feasible walking and biking could be for that school. And as you can see, in and around Vancouver, there are some with pretty low mean distances to school. And indeed, some of those schools have very high walking and biking rates, particularly right here where our health department is. Almost every student, I think, walks to school. So physical activity we've been talking about a lot, and that's only one side of obesity. The other big cause is access to healthy food, and so we measured that, and this is a data set that I'm kind of proud of, because a lot of jurisdictions try to measure health access to food and rely on industrial classification codes or food stamp databases. And we realized at the health department that, hey, we're the health department. We send inspectors to every place that sells food. So we worked with them to go through their database and classify each kind of food establishment. And we were able to map walking access to food. So on this side you see grocery stores and supermarkets, and we have network buffers for those. And there's about 15% of the county population is within a half-mile walking distance of grocery stores or supermarkets. But in unincorporated areas, that's about 10%. Fast food, on the other hand, we have almost 35% of the county is within a half-mile walking distance of their nearest fast food restaurant, or 26% in unincorporated Clark County. And I know it's a little corny, but I couldn't resist the ketchup and mustard effect on this map. So we looked at all these indicators, and what do we do with that? So in the rapid health impact assessment, we looked for where they were overlapping, where there were areas for great potential or areas of high need. And the way we determined that was measures of socioeconomic status for those social determinants of health, measures of the built environment for the built environment determinants, and then where are the outcomes lower than they should be. And so as a couple of examples of how we put all that together, these are two maps where the green areas represent areas of high potential and red areas represent areas of high need. And you can see that there's not really big contiguous blocks of potential and need, and it's kind of a checkerboard, really. But one pattern that did keep coming up over and over again is this area right here, south of the intersection of I-5 and I-205. I-5 is this one, and I-205 is right here. And east of about 182nd, kept coming up each time as both areas of need and potential. So in the rapid health impact assessment, we ended up recommending that the plan focus on that area. And to implement that, the planning committee, of course, established a prioritization scheme to choose the projects that were the highest priority out of the list of hundreds of projects that we had. And this is what they came up with for prioritization criteria. And you'll see that over there on the end, they awarded 20 out of the possible 100 points to health. And the way that breaks down within those 20 points is 10 points were scored based on socioeconomic status, 4 points were based on walkability potential. And we call it walkability potential because we're using that walkability index. And as I mentioned, it doesn't actually tell you whether there's infrastructure there. So I think of it more as a walkability potential index that tells you whether the sort of fundamentals are in place for a good walking environment. An additional 5 points was awarded based on connectivity, and low-stress facilities like a bike boulevard or an off-street path got 1 point. How do we do? So these are the proposed projects that are prioritized in the plan as it stands now. The red lines are sidewalks, green are trails, and blue are bikeways. And they're actually, in this plan, there are only bike lanes. None of the proposed bike boulevards made the final cut. But as you can see, there's kind of a lot of mileage beyond that focus area that we recommended. But many of the projects themselves are right in there. And so we wanted to look at the populations that these projects are serving. And so we drew a buffer around each facility and varied the width of the buffer based on the relative attractiveness of that facility. And the way we determined that was a little bit similar to what Nathan McNeil was presenting a couple of weeks ago. It was using the findings of the Portland GPS study that established sort of a relative attractiveness or willingness to deviate based on facility type. And there is definitely a degree of arbitrary distance cutoffs involved in this, but it was enough for us to move forward with. So the base case, kind of the index case, would be a bike lane at the service area being a quarter mile from the bike lane. And that's based both on what other plans use as kind of a level of service and on some research that shows that people are more likely to bike if they live within 400 meters. And then for a trail, that gets up to, I think, about a half mile. So looking at the population within that area, you can see that almost 95,000 people live within that area, which is about 45% of the unincorporated population. And when we break that down by socioeconomic status, you can see that about 26% of the proposed bikeway miles are in the lowest quintile of block groups by income, that's kind of what we were shooting for using that socioeconomic status and the prioritization criteria. I think one thing we didn't anticipate is that it looks like that maybe came at the expense of the middle income block groups, which was unanticipated. But it is what it is for now, and we'll have a lot of interesting findings when we look at the impact of the HIA itself. Looking at how, and I apologize for the typo. My girlfriend was kind enough to point that out to me as I was preparing this morning, but it's priority, not priority. But looking at the impacts of the proposed facilities, you can see that the bikeway network density really increases a lot in that focus area that we looked at earlier. One of the things that we'll look at when we evaluate the health impact assessment itself I'm sorry for the language, it's always hard to talk about the impact of an impact assessment. But when we do that, one of the interesting things will be to see, would this have happened if we hadn't included that prioritization criteria? But we were glad to see that for almost all of those census block groups, there's an increase in bikeway network density. For programs and policies, it's much harder to edge toward the magnitude of the change or magnitude of the impact. And so some of them are really kind of indirect anyway. And so we call those supportive of increased physical activity opportunities. But for others, there's some research out there, and there's some theoretical basis for showing that they will have a positive impact on health and increase opportunities for physical activity. These are the 5 programs that are proposed in the plan, and the top 2 are really sort of internal. and about streamlining the way that the county does bicycle and pedestrian planning. And so we call those supportive, obviously. And then the other three, let's see if these are self-explanatory or not. School education, that's mostly safe routes to school kind of programs. The Clark-Clovia is the Clark County spin on Sunday parkways. And then there is actually kind of a bit of bicycle tourism. There are a fair number of people that come to bike in the rural areas of Clark County, especially in the North County. And so the last program that's proposed is to develop a scenic tour in the East County to try to increase the bicycle tourism. The policies, similarly, it's really hard to make a comment on the direct impact or the magnitude, mostly because in a plan, it's not codified yet into, say, development code or capital facilities. So it's hard to say how much of the proposed policy will be implemented or to what extent. So because there's so much variability in implementation, we had a hard time commenting on the magnitude of the impact. But all of the policy areas are supportive of increased opportunities for physical activity, and if implemented, could have a really big impact. One success early on that we had is the recommended policies from the health impact assessment were many of them were included in the final proposal. And a lot of those are along the lines of active transportation and supportive land uses. And when you think back to that walkability index that we used, all of those things are sort of bigger, systemic things like land use and connectivity that supports cycling and walking. And if we only looked at projects, we could end up with lots of nice bike lanes and sidewalks and nowhere to go. So a lot of those policies are aimed at supporting denser development, a mix of uses, and integrated land uses. So I want to spend the rest of the time talking about some of the specific lessons that I learned or have learned so far in this. Some strengths of the effort have been, we got involved early on. The public health department and the planning department established a relationship pretty early on, and I think that was maybe a more productive model than typically is associated with health impact assessment. A lot of times when health impact assessment is discussed, it's talked about as if the health department receives a completed plan, then goes through it and marks it up to determine the health impacts, goes out to the community and asks them what they think the health impact is and what's important to the community. And I think being involved earlier on allowed us to do a lot of that work as the plan was being developed, so that our recommendations wouldn't have to result in sort of redoing the plan, which I think was really productive, and we saw a lot of results from that. The prioritization criteria, I don't think would have been in place had we not been at the table. And a lot of those active transportation policies, I don't think would have been included. There is a pretty extensive baseline assessment that we had a lot of time to research that, and we were lucky to have some good demographic, updated census data that we got from Esri. And as I said, the early involvement was good, not just for the outcome as it relates to the plan, but also it really helped us build a good relationship with the planning department. And we're at a point now where, as public health, there's a lot of interest from the planning department in having us involved, a lot of interest from not only the county planning department, but also the city of Vancouver and the Parks District that's there. So a key product, I think, of this health impact assessment is a good relationship with other planning agencies. And so moving forward, I think we can depend on having health concerns integrated into the decision-making process a lot more, which I think is a good product of this. Some of the challenges that we encountered were data needs, and I think that everyone says that, but especially for health data, it's really hard to connect it to built environment variables. First of all, because it tends to be cross-sectional, but also because we have a lot of rural areas in Clark County, and a lot of health data is based on surveys that are national telephone surveys. And so you end up with only a handful of responses in some of the outlying areas. And you don't have enough to report. And a lot of that is about privacy concerns. Also related to data needs is the state of the science and what some people expected from this health impact assessment. A lot of hope would be that we could say 300 people living near this sidewalk will have 10 minutes more physical activity per week, and that will have a lifetime benefit of, hundreds of thousands of dollars. But I don't think, both from the data input needs for something like that and methodologically, I don't think we're able to really do that. But more importantly, resource-wise, in the department, we can't do that. And that is also related to, I think, what policymakers and what some of the committee members look for as a result of an impact assessment. And they want to know things like, can we expect decreased visits to the emergency room? And what is the dollar amount that we will save from reducing obesity as a result of this bike lane? And I think as on both just staff resources and I think methodologically, I think we have a really hard time getting anywhere near that. And similarly, the drive to quantify things in economic terms, I think, is a challenge for us because the impacts of obesity are so complex that it's hard to tease out, how much of obesity is due to physical inactivity, how much of that physical inactivity is due to, personal behaviors, how much of it is built environment, determinant. So it's really hard to get to that level. Other challenges were just sort of weaknesses in the analysis, I think. We used a pass-through criteria when we were talking about the prioritization criteria. So instead of looking at how much mileage is within a census block group, we looked at whether a project passes through a low-income block group. So most of the mileage of that project could be in high-income block groups, and it would still get the points for being in a low-income area. And that was done for ease of implementation, because oftentimes it's, especially with prioritization criteria that you want to endure to continue to be useful prioritization criteria, having an easy analysis to do makes it a lot more likely that those criteria will be used. So I think if we had required an extensive GIS analysis for each project, I think it would be so onerous as to be set aside the next time it came time to prioritize projects. There's also a really strong focus to this point on where people live, which is, as anyone knows, that's only part of where you spend your day. So looking at employment centers and where people play at parks, we've done some of that. We are concentrating a lot more on schools now. But to this point, I think it's been highly residential in focus. And then finally, I think the last thing that I would want to discuss is just the network that we use to calculate network buffers for walking distances is the road network, which doesn't necessarily include off-street paths and trails or pedestrian and bicycle only facilities. So it could understate the population served by some areas. And I do want to briefly acknowledge the Robert Wood Johnson Foundation, which funded this health impact assessment, and also, as I mentioned, Esri, who made a data donation. And with that, I think the thing I want to leave you with is that there are a lot of good reasons for building bicycle and pedestrian facilities. And some of those reasons resonate with different groups, different decision makers, and different agencies a lot more than others. And health impact assessment is a great way to raise visibility of health as a reason for constructing bicycle and pedestrian facilities. So I guess the message is there are a lot of good reasons to build it. Health is one of them. But with that, I'll open it up to some discussion and questions. Yeah.
Remember about the microphones. If it's not working on your table or you don't have one, I'll bring one. But Brendon, I'll let you choose.
Okay.
Okay, I have a question specifically about the level of sophistication between the planning staff and the public health staff on each other's areas of expertise. For example, your understanding of pedestrian and bicycle facilities prior to going into this, and then what the opportunities and challenges were that you found with the education component with each of the staff from each agency.
It's a good question. I would say that I came out, I started this pretty much fresh out of graduate school, where I had been steeped in bicycle and pedestrian planning, spent a lot of time in this room, and I feel like I was very knowledgeable about bicycle and pedestrian planning at that point. Some of the planners have a good understanding of transportation planning and land use planning in general, and maybe haven't had the opportunity in the course of their normal work to focus on bicycle and pedestrian issues. But I think over an 18-month period, they became intimately familiar. But I would say where it comes to health, I think more of the disconnect would be around what's feasible to report. Can we say that obesity costs Clark County X million dollars every year? And then just clarifying some of the things I've learned about epidemiology, incidence versus prevalence of disease, and those kinds of things can tend to get confusing, even to epidemiologists, but translating that to the planners was a challenge along the way. But I'd say, for the most part, it's been a really good experience, and I think the relationships were definitely strengthened and will carry on to other efforts. Sure.
I have a similar question. I'm wondering kind of how much, it sounds like there's a lot of other agencies involved in creating the HIA, but how much is the public or community engagement actually involved, either in the rapid plan or the comprehensive one?
That's a good question. So the question is how much is the community involved and engaged in the development of the HIAs? And I would say not to the extent that some other HIAs have strived for. We work with a local nonprofit called Community Choices, and they focus on health equity. And so they've been sort of checking in with us throughout the process, working with their members. They have a health equity coalition, and so they've served as a sounding board to make sure that what we're doing is relevant to community needs. I would say we've also started working a lot with parks, and they do a lot of community outreach, and they have a good sense of community needs as well. But those are the sort of the main groups. There's also a newish active transportation committee of Friends of Clark County, which is another nonprofit, and they've been involved. I sit on that committee, so I'm communicating our work continuously to them. So that's been sort of the extent of community involvement.
There's sort of a related question from the internet, so I'll jump in here, and that is how long has the HIA process been going on here, and how many staff are involved? So maybe just a little bit about the resources to do something like this from the health department side.
Okay. The HIA formally kicked off in mid-January, and it will wrap up this coming January. The staff is mostly me, but the project team is our health officer, Dr. Melnick, who was going to join me today but couldn't make it, another senior manager from public health, and then the project lead on the plan. I've also had a lot of help from the assessment team at public health that does a lot of keeping track of health outcomes in the community and health determinants in the community. And so there are 2 epidemiologists there who have contributed. But I would say, in terms of what resources are required, a lot of this has been exploring how do we do health impact assessment. And so I think the next time we do something like this, it'll be faster and easier. So that sort of, and it's not the first health impact assessment that Clark County Public Health has done. There was another rapid health impact assessment done for a sub-area plan, like a neighborhood kind of plan. But doing something this in-depth is a new experience, and so I think a lot of it has been sort of those growing pains of figuring out how to do that. But so mostly 1 staff person for about a year. That's the short answer. We'll go right here.
Yes. Brendon, I have a question. Is it true that Americans were taking public transit and walking before the automobile era? And GM, I just saw a video on that. But to promote their car sales, slowly destructed the public transit systems and the habit of Americans to walk, bike, and other things, and slowly, by building the highways and selling the cars cheap, they destructed that. So is it true? And at any point in time, have you thought about that, including in your research?
Yeah, so the question is about kind of the history of how Americans became to be so dependent on automobiles. And I think there are a great many policies and actions that contributed to that over the last century or so. But certainly the decline of public transit and the subsidy of interstate freeways were huge contributors. The way I think we might incorporate that into health impact assessment is looking at, we've talked a lot about looking at the age of structures, the age of schools as part of a baseline assessment. Because certainly the older neighborhoods of Vancouver have a much higher potential for walkability. And a lot of the more sprawling suburban development to the north of Vancouver will be very difficult to retrofit if and when the political will were there. So I think that would be one way to incorporate it into a health impact assessment. But also, I think being more descriptive of what's going on now, talking about just what happens right now, how many people have access to transit now, what are the mode shares now, I think give us a good starting place to determine what we want, how we want things to change.
Thank you.
Sure. I'll go right here.
All right, I have like a 2-part question here. Is there a connection between low income and low bicycle usage? And if that's true, was there any compensation made for, you're going to build more bike lanes in more income places? are those people, is the low-income group going to bike as much as expected? Like, did you compensate for that?
We don't have any findings about, or any data about, or current data, I should say, about bicycling by income in Clark County. But the focus is to ensure that the opportunity is there, of course. And then I would say more generally, I think it depends, whether low-income people bicycle more depends a lot on where you're talking about. I know that I think Jennifer's research, I think, shows that there's a lot of bicycling around Fresno, which is has a huge agricultural and immigrant community. So it's very dependent on context, and I don't think we have very good data about that in Clark County. So.
On the subject of low-income areas. Sorry. So on the subject of low-income areas, I know that a lot of bicycle sort of improvements that get done, like the Springwater Corridor, are done on abandoned railroad rights-of-way or alongside major highways, places where low-income people often live nearby. So I was wondering to what extent you went to actually target the low-income areas, or to what extent those low-income areas were just sort of along the way of where you wanted to put the proposed improvement.
So the question is about how much did we target low-income areas versus how much was it just sort of more feasible to put a project there? And that's a really good question. And I think if we look at I might scroll back to the prioritization slide. So we did, out of the 100 points, 10 were scored based on socioeconomic status. But of all the rest of it, a lot of it was geared toward closing the bulk of. I mean, the largest category is closing gaps. So obviously where you have like a critical crossing or an unfinished portion, that was a big part. But really, the implementation, sort of getting at feasibility, was only 5 points of the total. So I think it's like 2 to 1. But if you wanted to quantify it. But I'd say for trails specifically for this plan, those largely came out of a trails plan that Parks has. And so to some extent they were sort of exempt from these prioritization criteria. I mean, there was a sort of a first cut, and then we looked at how those trails compared to the proposed trails in the Parks plan, and just tweaked it a little bit. So. Sarah?
So I saw, your timeline is that it's going to be wrapped up in January, which I'm excited to see. But then I have a question on that evaluation portion. And so, that evaluation was within that 1-year time frame. But I'm wondering, what if there is an extended evaluation that's going to happen, and if you could talk a little bit to the data issue, because I know some of the HIA folks in this region, the evaluation, they want to actually see the health outcomes,
right. And
we don't have data to see those health outcomes. So I was wondering if there's any sort of like data gathering component to it.
Yeah, so the evaluation that we'll do before January is really focused on the decision-making process and not so much on the outcomes. So we'll be talking to decision makers and to the people involved in developing the plan, and sort of extracting some key themes and really a lot of qualitative interviewing. In terms of the outcome measurement, I'll put in a plug for my coworkers project. Clark County issues an annual assessment, planning, and evaluation report that does track a lot of outcomes at the county level. It also tracks a lot of disparities. So we are looking at our outcomes improving, but also are the disparities decreasing. But again, that's at the county level, and it doesn't even speculate on the causes. So, so it will be very, very difficult, I think, to link those two. But we are measuring it. There's a question over here.
Oh yes, hello. Yes, I do. Yes, my question is also related to the lower income in regard to the middle income portion, the middle income being the least benefited by this recommendation. Do you think that there will be a process of displacement of long-term low-income residents from the areas in which they currently live, and that you're going to be adding facilities to because middle-income folks want to move into those areas? Essentially, are you concerned with gentrification in the low-income areas because of facility improvement?
I would say that the proposed facilities are fairly modest, and I would be pretty surprised if they sort of translated into a flocking of middle-income groups to a particular neighborhood. But I think gentrification is definitely a possibility. I would say more so in Vancouver than in unincorporated Clark County. One of the things we found is, we analyzed the whole county, not just the unincorporated areas, and we found that really the unincorporated areas are doing a lot better off by many measures. And so a key finding from the baseline assessment is that we need to be more involved with the city's planning efforts. So I think it would be much more of a concern there, but the current economic climate as it is, that concern might be a ways off in the future.
So I'm going to, since we're right up against 1 o'clock, but we had a couple really good questions over the internet, I'm going to throw one of them out there that I'm hoping you can answer quickly.
Okay.
And that's whether or not you think, because of this experience, if Clark County will be doing some additional HIA work related to the built environment, such as on economic development plans, or do you think this experience is going to take it further, perhaps on some more controversial types of plans rather than a ped bike plan?
That's a good question. So will we be doing more HIA work? And I think the answer is definitely yes, but we'd really like to see things move in the direction of having health considered in all policy decisions as a matter of routine. And that would make it so, if we eventually get to that point, it will make it so HIAs are much less, maybe there's not an urgent requirement that we do one. But I would say in the near term, we've already done another rapid health impact assessment on another neighborhood plan that's still in the planning process in the Salmon Creek area. We are working with the planning department to create a health chapter in the comprehensive plan update. We're hoping to do that, and that would kick off next year. But in terms of future HIA, I think what we've really got from this HIA is a better sense of existing conditions and where specifically they are. We knew there was need, and the baseline assessment from this HIA has really helped us determine where most of that is. So I think we'll do a better job at screening in the future and being less opportunistic about doing HIAs instead of just every request that we have say, yeah, we want to do an HIA, sure. Sort of being more strategic about when and where we do HIAs, I think, will be an outcome of this experience.
So since we're at 1 o'clock, I'm going to have to cut off the formal Q&A. I'll first, before we thank Brendon, put a plug in for next week. Different type of topic, as happens with our transportation seminar series. Kristen will be here talking about Portal 2.0, the next generation of archived data user service. So we hope we'll see some of you there. Thanks.
Thank you.